So today I wanted to do a rapid psych review. Really quick, easy diagnosis, how to differentiate this versus that. I'm finishing up my psych rotation now, and this is helping me kind of go back through stuff, but then also kind of how I'm attacking stuff for step two. So kind of the step one relevant stuff as far as I'm concerned for you guys. So let's get to it. I'm going to try to be as quick as I can, give you what you need, and that way this video is as fast as possible. But there is a lot to cover. So what to expect. These are going to be quick, easy, memorable ways to differentiate things. I'm going to give you the bare minimum, simplest way that I go about it. Um, Again, it's not always going to be the most accurate or perfectly correct way to do it, but this is how I do it on the test because from my experience, what coursework was like during second year was not the same as what it was like on practice exams and then on boards. It's much, much easier on boards. Psych really is easy points. So another thing, time frames are super important. So yes, you do end up having to memorize them. This list is not comprehensive. There's a lot of things I left out because I just felt like they were either easy to cover or not quite as hard to differentiate from other stuff. One big key here is rule out medical diagnosis. First, check their medications. Someone comes in and tells you they've been depressed for a month and you look back and you gave them a beta blocker 2 months ago, yeah, that absolutely could be the reason. Next, memorizing the DSM-5 criteria for most disorders is absolutely a waste of time, useless for you, which is contrary to what would have been pushed on us in class. There's really only one disorder where I'm going to tell you that you should definitely know the criteria, and we'll get to that in a second. Also, not covering treatments. There's too much complexity here to go into that. Maybe a different later video, but not today. Just real quick, easy, rapid diagnosis stuff for the most part. So we're going to start with the psychotic disorders. The ones we're going to cover first, brief psychotic, schizophreniform, and schizophrenia. I'm going to start out by saying these three are the same damn disease, okay? They have the positive symptoms you expect, the hallucinations, the delusions, the paranoias, things like that, things that are there that should not be. That's why it's a positive symptom. It's there and it shouldn't be. And then also the negative symptoms, they have those too, the flat affect, kind of not really interested in anything, things that aren't there but should be. Your typical schizophrenia patient. So the only way you differentiate these is time. That's it. 1 day to a month, brief psychotic disorder. 1 month to 6 months, schizophreniform. Greater than 6 months, schizophrenia. The disease does not change, but the patient's projected outcome and how you treat it is what changes and why you have these differentiations. Really nothing harder than that here. Keep it as simple as you can. Now, one thing I'll tell you, because I've had questions that have kind of hit on it, is as far as diagnosing these, it is the onset of any symptom, okay? Just because their psychosis started 2 months ago, which would put them in schizophreniform, if they had negative symptoms a year ago, they have schizophrenia at this point, okay? It's the onset of any symptom, and they just have to meet the full criteria of schizophrenia for at least a month is what I was reading. So make sure you note that, the onset of symptoms. All right. Now, schizophrenia versus schizoaffective versus major depressive with psychotic features, because these are tested against each other a lot and making you identify them. So schizophrenia, just like we talked about above, psychosis is the predominant thing with these. Yes, you can have some mood disorders, but it's a little tiny piece of it, okay? Just this minor thing. Now, schizoaffective is kind of the middle ground where it's mixed. You have depressive and psychotic symptoms, but the key here is you have to have an episode of psychosis without mood symptoms for at least 2 weeks. Okay, so psychosis on its own. So in the STEM, they will go out of their way to somehow push that when they were younger, they had this episode of hallucinations and delusions, but they didn't have any depression or anything, and they tell you it was 3 weeks long. There, you got your answer. They have to go out of their way to tell you that stuff. Now, moving on. Major depressive with psychotic features. This is depression predominant, and there's psychosis only in the presence of mood symptoms. So they meet the criteria for major depressive, but they're also hallucinating, but they only have those features when they're depressed. That's it. That's how you differentiate those three. Okay? Now, delusional disorder and schizophrenia. I know delusional disorder doesn't really fit in here, but it'll make sense in a second. So, delusional disorder is someone who has a perceived delusion for more than a month, and they have these thoughts, this continuing delusion that, despite evidence, is still there. And the easiest way to think of it is these delusions are believable. This is the guy who thinks his wife is cheating on him, but even though for the last year and a half he's hired a private investigator, he's tapped her phone, he's checked her texts, he's read her emails, he's showed up at her work unannounced to look and try to find evidence of this, but he still believes it even though he's found nothing. That's delusional disorder. It's realistic. His delusion is realistic, but in the face of obvious evidence, he doesn't change. So that's delusional disorder. Schizophrenia, theirs are crazy. This is the government is watching me because I'm special. They've replaced my mom with a robot so they can keep better tabs on me, and they're trying to kill me. Out there, okay? Real simple, not perfect, but kind of an easy way if you're between the two, well, I don't know, you can fall back on something like this. All right, moving on to the mood disorders. Something I'll put in here, adjustment disorder is not technically a mood disorder, but it fits in here well. So we're going to start with bereavement, so normal grief, adjustment disorder, major depressive, and dysthymia, which is persistent depressive disorder. First one being major depressive. So this is the only one where I really think it will be good if you memorize the DSM-5 criteria, and not even exclusively out of it, but just this mnemonic here, the SIGI CAPS mnemonic, to where you need to know every little kind of piece of that. So with this, you have a person who has, reports a depressed mood and 4 or more of these SIGI CAPS symptoms, with that being, a change in sleep pattern, a loss of interest in things they used to like, guilt over something, low energy, poor concentration, a change in their appetite, which it can either be an increase or a decrease, psychomotor agitation, so they might have, a tremor or some weird symptoms, maybe they're a little clumsy or whatever, and then the S being thoughts of suicide. As soon as you hit depressed mood and 4 of those, I don't care what the rest of the STEM said for the most part. This diagnosis superseded everything on any practice question set I ever did. Okay, I might be looking as like, oh shoot, I'm not sure if it's this or that, and the person met the criteria, it was automatically major depressive. It's an easy way to go. So that's why I think this one, memorizing this criteria, is important. Literally count it on your fingers, because in the STEM, you're going to notice they're giving you a whole bunch of symptoms, and as soon as you hit depressed mood plus 4 of those, you've got your answer. And that's that. Now, going to bereavement or normal grief. So it doesn't meet the criteria for major depressive, and it's less than a year. This is the woman who her husband died, and she's not doing great. Her appetite's okay. Some days she doesn't eat. She's able to go about her work, but, if she sees something that reminds her of her husband and she gets upset. The normal, if someone dies, you should be upset, but not, it doesn't fall into the criteria of major depressive and meeting that SIGI CAPS mnemonic. And it should be less than a year. Anything more than a year has now changed to persistent bereavement, but I didn't leave that in here. Adjustment disorder. So this, like I said, is not technically a mood disorder. It's a stress or trauma-related disorder. But again, it doesn't meet the criteria for major depressive. It comes up within 3 months of a stressor and is gone by 6 months. So this is a kid who moves away to college and just kind of not in a great mood. Maybe he's not eating well, but he's sleeping fine. He's still able to do his homework. He doesn't meet that major depression criteria, but there's an obvious stressor. Or, a woman who just had a divorce and kind of the same thing. She's able to function, but at a little bit lower level, but it doesn't meet the criteria. That's that. And then dysthymia is literally just major depressive disorder, longer than 2 years, with no periods longer than 2 months where they were okay. They didn't have the depressive symptoms. That is dysthymia or persistent depressive disorder. All right, moving on. So bipolar 1 versus bipolar 2. When it comes to bipolar disorder, the only thing that really kind of, what sets these apart is mania, the symptoms of mania. These are the people who don't have to sleep for days. They have these racing thoughts, pressured speech. They're, come up with all these plans to solve world hunger and, get housing for all the homeless people, and they need to talk to the president because he's just going to understand. That's mania. They're on cloud nine, running hot all of the time. So with that, how do you differentiate these two, bipolar 1 versus bipolar 2? Because bipolar 2 is technically hypomania. So bipolar 1 is, an actual manic episode. That's all you have to diagnose this. And impaired functioning is the big thing here. This person has a manic episode, and in some form of their life, there's an impairment, whether it's in a relationship, personally, at work, something. They are impaired somehow. Whereas bipolar 2, it's hypomania, so not quite as extensive of a manic episode, but an easy way to define it, no impairment. This is the med student who, for a couple of weeks, doesn't really need to sleep, studies really, really well, kills his test, and then kind of comes back down to normal. There wasn't a functional impairment there. Or, an attorney who works like crazy for, a few days, gets a whole bunch of stuff done. It actually made they were more successful. So again, just an easy way to see, someone with bipolar 1, you're going to see impairment. Not that you can't with bipolar 2, but if you don't see impairment in someone and you're thinking bipolar, you're going bipolar 2 here. Now, again, with bipolar 2, you can have some mild depressive symptoms in there with it. It's not necessary for diagnosis, but typically is present. Now, bipolar 2 versus cyclothymia. Bipolar 2, again, same thing we just talked about. Cyclothymia being the same disorder, except these people kind of shift from these mild depressive episodes to hypomania and then back. And they're, just like dysthymia, it's greater than 2 years, and they're never symptom-free for more than 2 months. So they're kind of always riding that line where they always have something. Where someone with bipolar, they can be fine and then have a manic episode, and then they're fine, then a manic episode. These people, they're depressed, then they're hypomanic. They're depressed, then they're hypomanic. All right. So postpartum mood disorders, pretty simple overall, but we're going to run through them anyways. Postpartum blues, mild depression. These are people who, I don't understand why I'm upset. I love my baby. Why? Something's missing. But it's very mild, lasts less than 2 weeks. That's the key there. Cannot last more than 2 weeks. Postpartum depression basically looks like major depressive disorder. These people think they're going to be a terrible mom. They don't understand why they're so upset. Everything's so hard. But basically meeting the criteria for major depressive. And it starts within 4 weeks of birth, okay, from that actual birth. Now, you can look online, and there's going to be some differing things on this, and I was checking into it. But technically, according to the DSM-5, if you have a woman who says that her symptoms started at 6 weeks postpartum, that is major depressive disorder. According to the DSM-5, that technically cannot be postpartum depression. If it's within 4 weeks, now it can be. And this is a little more serious. You need to treat this. Okay, postpartum blues will go away on their own. Postpartum depression, you need to treat it. Postpartum psychosis, depression with any psychotic feature. These women are at risk for harming their baby. They're hearing voices saying they should kill their baby, or they're a terrible mom. Hospitalize them. That's the end of it. That's how you differentiate those three. There's not necessarily a time frame on that one. Just look for the psychosis. All right, anxiety disorders. First one being panic disorder and agoraphobia, because these go really well together. So panic disorder, these people have panic attacks, and then you have this continuous worry about the next attack for more than a month. And then they have another attack, and then they start avoiding things because of the attacks, because they're so scared of when the next one's going to happen. So they start having issues in their life. That's the key here. Panic disorder, they have to have a panic attack and then be really, really bothered, and this excessive worry about when is the next one going to be. And then with that typically comes agoraphobia. It's their fear of being in a situation that they can't escape from. So like being on a public bus or at a museum or something, they can't get out. They have to find an exit, and it would be hard to get away. And it typically comes kind of with panic disorder. All right, social phobia, performance anxiety, and specific phobia. Social phobia, literally just fear of any social situation. These people don't like to talk in front of people. They don't like to be around people because they're anxious, nervous, don't want people. They're uncomfortable in crowds. It's kind of the simple way to put it. Performance anxiety is a fear of a specific social situation, whether it is specifically every time they give a speech is the only time they have issues, but between that they're fine. Or an athlete who gets really bad anxiety before a game, or a dancer or a singer who gets really bad anxiety before they go and perform, but at other times, at other social situations, they're fine. So it's kind of a specific phobia merged with the other one. Now, specific phobia, fear of one specific thing, whether it's bridges or spiders. So this is the patient who has a fear of bridges, and they go way out of their way to drive to work every day to avoid the one bridge between them and their work. It costs them an hour every day, but they don't care. They need to be away from it. And then if they're going on a trip where they know they have to go over a bridge, they stress hard for the days prior. One other thing is the patient is aware this is irrational with a specific phobia. They are aware. Now, generalized anxiety disorder, literally this simple. They're worried about everything. That's all I want you to know. They're going to list multiple things that this person is worried about, and we're done. All right. Obsessive compulsive and related disorders. Kleptomania doesn't perfectly fit in here, but I liked it. It's actually an impulse disorder, but moving on. So, obsessive compulsive disorder. This is a word that's thrown around a lot, but really easy to diagnose. Now, so patterns of intrusive thoughts or obsessions that cause distress as well as repeated compulsions or actions in order to get rid of that feeling. Distress goes up if they don't perform them, and they get a sense of relief when it is performed. One big thing is the patient knows it's not normal. It's called ego dystonic. They don't want to be this way. And it causes life issues. This is someone who has to wash their hands X amount of times before they do anything. They check to make sure everything's unplugged in their house for 2 hours, which they know is excessive. They're worried about someone breaking into their house, so they do, 3 laps one way, 3 laps the other, and then make sure and check every lock, every door, things like that. You think of obsessive compulsive, but it can even be as vague as something like, a person has these intrusive thoughts of, killing people that are around them all of a sudden, and in response to that, they have to walk away, and they have this way that they count down from 5, 4, 3, 2, 1. They do it over and over and over, but it doesn't necessarily make the thing go away. But every time they have that intrusive thought, they do that. It can show up that way. So it is these thoughts that come back over and over and lead to compulsions. All right, so the next 4, first one being body dysmorphic disorder. So this is excessive concern over a perceived physical defect, whether it be like a mole or saying my nose is big, and it causes functional impairment. And realistically, in these people, it's usually not a big deal. It's something other people won't notice, and they're going to go to excessive lengths to cover it up. So they wear gloves because they have this one little freckle on their hand they don't like, or they spend 3 hours doing their makeup to make sure people don't see this little darker skin patch on their face. And it causes issues. They miss school, they miss work, it messes with relationships. Next is hoarding, so inability to discard objects, like trash anything, and it causes distress if they try. Trichotillomania is pulling out of their hair in response to stress. One thing to watch out for here is a kid that comes into the ER with signs of like a bowel obstruction, and you notice that there's patchy hair loss, right? Because they've been pulling it, eating it, and they have a gastric bezoar. So that's a way that can show up. Kleptomania, they have a persistent urge to steal, but the objects are insignificant. So this isn't someone who has this urge to go and steal cars. No, that person's an ass. And it's another diagnosis we'll get to. They're stealing food, paper, gum, stupid little things, but they need to. They have this, they've got to. And when they do steal, they get a sense of relief and distress if they don't. So that's a big thing here, is it's insignificant objects that they're compelled to steal, lipstick or something really small. All right, so trauma and stress-related disorders. Again, these are absolutely identical, okay? So with acute stress disorder and PTSD, a person witnesses or undergoes a life-threatening exposure and then subsequently has insomnia, nightmares, replays the event intrusively, kind of these intrusive thoughts. They have hypervigilance where they're always on guard, and they kind of socially isolate themselves, and they're kind of living in their own personal hell. The only difference here between the two, Again, just like the schizophrenia, it's time. Acute stress, let 4 days to a month. So really just under a month is kind of the easy thing. PTSD, anything over a month. That's it, you're done. Okay, timing, that's it. Now, jumping over to some pediatric ones, I know that for me, this wasn't taught in the curriculum, which is frustrating because they're both pretty big disorders that show up on boards. And they do go after these two. And then pyromania, again, being an impulse one, but it fits here well. So oppositional defiant disorder versus conduct. Oppositional defiant is a kid who purposefully disobeys authority figures but doesn't have severe features. And you'll see what I mean by that in just a minute with conduct disorder. So they don't listen to their mom, they don't listen to their dad, they don't listen to their teacher, they don't listen to the principal. They're purposefully defiant to authority figures, but they're fine with their friends. They're not going out of their way to be an ass to people. Whereas conduct disorder, again, less than 18 years old, and you'll see why that's important. Literally the worst kid you can think of. Total jerk, criminal, abuses animals, goes out of their way to destroy things of other people just to see them hurting. Just a piece of crap, okay? One of the things here is a prerequisite for antisocial personality disorder as an adult. We'll get to that more in a minute, but just want to throw that in there. That's why the under 18 years old is important. All right. Now, pyromania, this one can get confused with conduct disorder pretty easily, except the difference here is that this kid sets fires for pleasure. Just like kleptomania, where they stole to get that sense of relief, this kid lights fires to get a sense of relief. He enjoys watching the fire. He gets like a high out of it or pleasure from it. That's pyromania, but they're not lighting stuff on fire or lighting, their neighbor's shed on fire because they're a piece of crap and they want to see their neighbor angry and hurting and they want to be just, the bane of everyone's existence. They do it because watching the flames gives them pleasure. Okay, that's the motivator here. All right, pediatric attention disorders. So absence seizures obviously doesn't fit here, but it's tested against ADHD a lot. So I threw it in and we're going to talk about how to differentiate these two because it will come up, I guarantee it. So ADHD has issues with distractibility in multiple settings, both at school, home, say if the kid does karate, any other setting. This kid, he can't focus in school. He blurts out. He doesn't do his homework when he gets home. He won't do his chores. He frequently forgets stuff, doesn't turn in assignments, and you usually do poor in school, as they present to you. But one of the things they're going to test against, again, the big thing here, multiple settings. If this kid only has these issues in school and everywhere else he's fine, it is not ADHD. It's some other issue. Okay. Now, absent seizures. This is the kid that in class stares off like he's not paying attention and the teacher tries to get his attention and he won't respond. Then all of a sudden he's kind of back and he doesn't realize that, he was out of it. And, the teacher writes home to the mom that he needs to be checked for ADHD and blah, blah, blah. That's the absent seizure. The kid who's staring off in class or, you talk to him and it's like he's not paying attention. Then all of a sudden he's back, but he doesn't remember the episode at all. Pay attention for that. There's some more step 1 and 2 relevant, like little nitty-gritty details about it, but these are tested against each other a lot. So just be able to identify that. Just because you see a kid not paying attention in class, don't automatically assume it's an ADHD. Go looking for the other features. All right. Personality disorders. There's a lot of them. The first thing I'll tell you is, personally, I think it is a big useless waste of time to sit and try to memorize what are the cluster A, what are the cluster B, what are the cluster C. As far as step 1 material went, I don't ever remember seeing a question that made me diagnose someone and then ask me which of these other disorders is in the same cluster. Now I have had some other resources ask me that, and I literally laugh every time because who gives a crap? It's more important for you to be able to identify them. So just in case, just as a quick review, the cluster A personalities are paranoid, schizoid, and schizotypal. These are the weird personalities. And of note, these have a predisposition for schizophrenia. Just something to kind of keep in mind there. These are cluster A. These people, they're weird. Cluster B are wild. These ones, have a predisposition for mood disorders and substance abuse. So again, just that's there for your memorization enjoyment. Cluster C, these are worried, and these people, obviously, since they're worried, are more predisposed to anxiety issues. And we're going to kind of go through, compare, and contrast the different ones as we go. So, paranoid personality, real simple, they don't trust anybody at all. Doesn't matter. Everyone has an ulterior motive and they're out to get them. That's it. But they don't have the psychotic symptoms of, hearing, seeing things, someone told, the walls told me this. Just, they've always been paranoid. Next, schizoid versus avoidant, because they're very similar with one key difference. So schizoid, this is a loner, and they're perfectly fine being alone. No issue. That's how they want it. They've never been in a relationship. They work as a nighttime toll booth worker, and they are happier than they could be not being around anyone. They just don't care. They sit in their basement, they play their computer games, and that is it. They don't want to be around other people. That's schizoid. Versus avoidant, where they are a loner, don't really have friends, but they want to. They want to have those relationships, and it's that simple. They're just afraid people will think that they're weird or not worth their time. That's avoidant personality. They are avoiding the possible rejection there. So those are always tested against each other. Next one, schizotypal, big weird. These are the people that believe in dragons, worship stars. They dress really odd kind of combinations that you wouldn't see on a normal daily basis. And they have poor social skills. It's that simple. Those are the people you're looking for. Kind of just flat affect, don't really make eye contact, and they just really in the questions will typically tell you something about what they're wearing. All right. Antisocial versus narcissistic. Not that these are perfectly comparable, but they do tend to end up in answer choices together as a compare-contrast. So antisocial, this is the adult form of conduct disorder. Again, they're the criminal, they're the piece of crap. One thing to note is you have to have evidence of conduct disorder before the age of 15 to diagnose antisocial personality. Okay, so you cannot diagnose a 25-year-old with antisocial personality disorder if this is something that just started last year. Something else is going on. You also cannot diagnose a 14-year-old with antisocial personality disorder. They must be older than 18. Okay, now narcissistic. These are egotistic, rude, hypersensitive to criticism, and they react violently to any shots at their ego. These are the people where you have to kiss their ass repeatedly, and they have no empathy at all. You tell them that, hey, I don't really like the outfit you're wearing, and they grab you and slam you against the wall because they thought it was a good outfit. They can't handle criticism at all, even if you weren't being rude, even if it was one of your better friends. That's this person. All right. Borderline, histrionic, independent. Again, kind of the same loose association, but they are usually answer choices. Borderline, they attach aggressively and will avoid abandonment at all costs. These are, a woman who is scared her boyfriend's going to break up with her or is about to break up with her, so she swallows 200 ibuprofen and then calls him and says, hey, help, I need help, I just did this, I tried to kill myself, come save me. They will threaten suicide over and over, but the problem is they will actually attempt it, but they usually will give someone a heads up so that they can save them. So even though, yes, they do survive the attempts, decently often, they're at risk of not surviving it. So suicide risk is here. Also, splitting is one of their big features. If you see someone saying that this doctor is amazing, this person's amazing, but their last doctor, completely incompetent, this stupid idiot, people are either amazing or terrible, that's borderline personality. Histrionic, must be the center of attention. They're sexually promiscuous and easily attached to. They make best friends in 2 weeks, but then they'll also abandon people. But this is someone who, at a party, if someone else is stealing the show, they are going to go and they are going to one-up them by doing something that may not be socially appropriate. But they got to be the center of attention. Think about celebrities. That's what you think of a lot of times. You watch TV and it's like, Jesus, what is wrong with you? Why do you have to have so much attention? Yeah, histrionic personality. Then dependent. These people, they attach pretty aggressively as well, but they cannot function. outside of a relationship or without someone there to depend on, whether it's a parent, a boyfriend, girlfriend, husband, wife, whoever. They literally could not do the basic daily things without someone there kind of making decisions for them and doing it for them. So those are those three. Next thing is obsessive compulsive personality disorder, in contrast to obsessive compulsive disorder. This is what a lot of people, laymen say, oh, I have obsessive compulsive because I need things to be this way and this way. No, that's obsessive compulsive personality. Just a pet peeve of mine. But this is the perfectionist to the point of personal sabotage, where they get fired because their work is always late because they spend so much time making sure it's perfect. They are inflexible. They are obsessed with being on time and other people being on time. This is the husband who made dinner plans with his wife at 6 o'clock, but on the way to dinner, while she was driving, a tire blew out and she had to wait for AAA to come and replace it before she would get there. She gets there 10 minutes late and he can't even handle it. He cannot process, why are you late? How are you late? Even though he knew the situation. That's that person. Also, just like in the contrast to obsessive compulsive disorder, these people are unaware of the issue because this is who they want to be. It's egosyntonic. So there's that. All right, moving on to the next ones. Somatic symptom and factitious disorders. So somatic symptom disorder and conversion disorder, not that they're similar, but again, tested against each other. Somatic symptom disorder is a preoccupation with one or more physical symptoms. So this person might actually have a disease. Maybe it's knee pain or neuropathy or something, but they are so preoccupied by it that it causes impairment and distress in their relationships, their job. There has to be a marked life impairment over focusing on this one problem that they have. It's excessive. Whereas conversion disorder is basically stress-induced neurologic problems that you can't explain by a medical diagnosis. This is the person who comes in and they say, both of my hands are numb. It feels like I'm wearing gloves. And through anatomy, you know that there's not a nerve or even really a reasonable combination of nerves that would cause numbness in kind of that stocking glove pattern. So it is stress-induced. It's a physical manifestation of a mental illness. Also, another thing here is they may seem indifferent to their issue. They might come in and say, yeah, I woke up this morning and I couldn't see. And then you would expect them to be freaking out. If I woke up blind one day, I'd be losing my mind. But they're just kind of like, yeah, this sucks. And that's it. It's called label indifference. So if you see that kind of thing, the answer is conversion disorder almost every single time. All right. Illness, anxiety disorder, excessive fear of a serious illness, even though they might have little or no symptoms, and test results show them it's negative over and over and over. This is kind of an alternate to factitious, where these people don't really have symptoms. Whereas factitious disorder, these people kind of falsify or create these symptoms on their own to assume the sick role. That is what they want. There's not this secondary gain. They like being the person who's being taken care of or whatever, just for whatever reason, that's what it is. And again, this can be imposed upon a child. So this might be the kid who has diabetes, and the mother either, over the course of a few years, you notice that the kid's coming in for DKA like crazy, and you find out that her mom's not actually giving her insulin, even though she says she is, because the mom is imposing her disorder on the child because her mother likes to be the person who's being taken care of and assume a similar sick role. Okay, so pay attention for that too. And then malingering, there's an obvious intent. This person wants money or this person wants time off. This is someone that unfortunately you think of with like some workers' comp cases where they're going to exaggerate the crap out of it to go get money. Or the person, cough, cough, I'm sick, doc, can I get a work note? And their intent is because they want to go on a boat fishing that day. That's malingering. So there's those two. Now, eating disorders. Super simple, something that I thought was not articulated well during curriculum. Literally probably the easiest thing on all of them. The only thing I give a crap about when it comes to eating disorders is the BMI. If their BMI is less than 18.5, or less than the 10th percentile for some tests that like to throw that at you, the answer is anorexia nervosa. I do not care. The answer is anorexia nervosa if the BMI is less than 18.5. If it is over 18.5, it cannot be anorexia. It is bulimia nervosa. Now, let me explain why I'm emphasizing this. When you think bulimia, you think of someone who binge eats and then they throw it up, or they go to the gym, they run like crazy the next few days to compensate for it, right? They have this, binging, purging. But if their BMI is 18.6, that's bulimia. If their BMI is 18.5, it is anorexia. It is the same disorder. The only defining feature on your test that you need to look for is where's that BMI? Is it above or below 18.5? And if they give you percentile, is it above or below 10? That is it. Now, differentiating bulimia nervosa and binge eating disorder, really simple. One other thing. So obviously, it's going to be a BMI over 18.5, inherently, because we've ruled out anorexia. Bulimia nervosa, they binge eat, and then there's compensation. They're throwing it up, they're taking laxatives, or they're exercising like crazy is what shows up. Binge eating disorder, they binge eat, no compensation. They feel guilty, but they don't do a damn thing about it. That's it. That's eating disorders. So if I can go back and emphasize to you, literally as soon as you realize this person is there for some psych thing, or you see anorexia and bulimia as answer choices, go see if they gave you a BMI, because they must to be able to diagnose this. And then you have your answer automatically. All right. So that's it. That is your rapid review, taking care of everything, kind of just real simple pieces to differentiate this versus that, not spend time on psych questions, because they should be easy points as far as diagnosis goes. Obviously, I said the farm is a little bit harder, but that's that. So if there's something else you want me to cover and make videos, comment below, send me a message on here, doesn't matter, and I'll see what I can do about making you guys videos. You can subscribe, and that way if I post anything, you kind of get your up-to-date stuff. But again, I hope this is something you can throw on like 1.5, 2 speed as you're starting dedicated, and just fly through stuff as a quick reminder of what's what and how to differentiate it. But hopefully this helps. Leave some comments, let me know. Thanks, y'all.